Different commercial ports are available to try and seal the wound to prevent gas leakage, and some of them are demonstrated here for you. Some involve a balloon, as you see here, which allows the wound to be sealed. Familiarize yourself with the Verres needle. Its tip consists of a sharp outer needle and a blunt inner obturator. The spring mechanism is designed to allow the obturator to retract into the trocar as it encounters resistance while passing through the abdominal wall. It then springs back once the peritoneal cavity is entered. At its hub, the Verres needle has a valve with an open and closed position, and the valve should be maintained in the open position at all times during use. Ensure that the Verres needle is assembled correctly and that the mechanism works freely and without resistance. Ensure too that the channel is patent, which is usually best confirmed by flushing it with saline before use. Now choose a suitable site for entry on the anterior abdominal wall. The umbilicus is frequently chosen in the virgin abdomen, as the skin, linea alba and peritoneum are fused here as a single layer. Make an incision in the skin. This should be sufficiently large to accommodate the primary trocar you will be using once pneumoperitoneum has been created. Take the Verres needle and hold it in your fingers like a dart, just a few centimeters away from its tip. Do not hold it at its hub, as this position does not permit a sufficiently controlled entry. Use a suitable instrument in your other hand to grasp the anterior abdominal wall. In this model, towel clips are most convenient, although in the clinical setting, Alice or Littlewood forceps applied to the linea alba are often employed. Controlled entry is achieved by lifting the anterior abdominal wall onto the Verres needle rather than by pushing the Verres needle into the abdomen. When the peritoneal cavity is entered, a single click will be felt and heard. Now point the Verres needle from the perpendicular towards the pelvis and gently advance it a little further into the peritoneal cavity. The position of the Verres needle should be checked to ensure that it lies freely in the general peritoneal cavity. Attach a syringe to the Verres needle and attempt to aspirate. There should be no return. Now instill 10 ml of saline, which should encounter no resistance as it dissipates into the abdominal cavity. A drop test should also be performed. Place a drop of saline into the hub of the needle with the tap in the closed position. When the tap is opened, gentle elevation of the anterior abdominal wall will result in the meniscus of saline being sucked into the peritoneum. If these tests do not confirm the satisfactory positioning of the needle, gently rotate it or withdraw it slightly, as the tip may lie within the omentum. Repeat the tests until you're confident that the tip of the needle lies in the general peritoneal cavity. When the position of the Verres needle has been confirmed, the gas tubing may be attached and the insufflator set to a low flow setting. Gas should flow freely without any appreciable rise in intra-abdominal pressure. When 200 ml of carbon dioxide has been instilled and the pressure remains low, the flow may be turned to a faster rate. High flow will confirm that the tubing is not kinked. 4-quadrant percussion of the abdomen will demonstrate that the peritoneal cavity is distending uniformly. Ensure that the pressure cutoff for for the insufflator is set to a suitable level, usually 12 to 14 millimeters of mercury. In the relaxed patient under general anesthesia, 3 to 5 liters of carbon dioxide is typically required to achieve this pressure and to cause the insufflator to automatically cut out. In an adult patient, any volume significantly lower than this is unlikely to be enough to ensure adequate distension for insertion of the primary trocar. The primary trocar may now be selected. Familiarize yourself with the trocars, as a wide variety of designs exist, and it's important that you're confident with the actions of those you will be using. Trocars are available in different sizes, but those most commonly used are 5 mm or 10 mm in diameter. Larger trocars can be adapted for smaller instruments with downsizers, but plan to use the smallest trocar appropriate for the operation anticipated. Some trocars are totally disposable, some are hybrid and semi-disposable, whilst others are fully reusable. These distinctions are important as different ports are designed to be inserted in different ways. Some instruments, particularly disposable ones with very sharp blades, should be inserted by applying direct, continuous, longitudinal pressure. Most trocars like these have a retractable guard, which, once primed, is designed to pop out as soon as the peritoneal cavity is entered, thus shielding the blade from damaging deeper structures. Whilst useful, these guards cannot be relied upon to prevent internal damage arising from poor technique. Other trocars, including most types of reusable instruments, have a shaped or beveled tip, and these are designed to be rotated through the tissue planes with a twisting action. Some are deliberately blunt for use in open Hassan insertion. It is therefore essential that you understand the design and mechanism of the instruments and their intended method of use before insertion. Once pneumoperitoneum is established and the abdomen is distended, ask your assistant to apply additional counter-traction to the anterior abdominal wall by compressing the sides of the abdomen. Remove the Verres needle. Now take the primary trocar and hold it comfortably in your dominant hand, and use your other hand, or just an extended finger, to act as a stopper to guard against precipitous entry. Point the trocar towards the pelvis and insert it firmly but gently, avoiding jerky movements. As soon as the peritoneal cavity is entered, a distinct give will usually be felt. Stop. Remove the obturator, and only then should you advance the trocar further. If the gas tap is opened, a hiss of gas will confirm appropriate positioning of the primary trocar in the peritoneal cavity. The gas tap tubing is connected, the abdominal pressure setting reduced, and the camera then inserted for diagnostic laparoscopy. Assess the abdomen and identify the optimal sites for insertion of the secondary ports, which are inserted under direct vision. These sites must be free from abdominal adhesions and are placed to allow triangulation of the working instruments to the target organ. They should be placed far enough away from the target organ that the fulcrum of the anterior abdominal wall rests at the midpoint of the instruments being used. Check the position of the incision on the anterior abdominal wall by palpating with a finger and incise the skin with a knife blade. Select the appropriate trocar. It is helpful to acquire the habit of inserting the left-hand trocar with the left hand and the right-hand trocar with the right hand, a technique which will automatically ensure that the port is traversing the anterior abdominal wall in the direction in which it will be used. This is especially important in the obese or very muscular patient. The same degree of care is required for insertion of secondary trocars as for the primary trocar. Remember to use slow, steady movements, using your spare hand as a stopper to prevent uncontrolled entry. All secondary trocars must be inserted under direct vision. Once the trocar is seen to be through the peritoneum, remove the obturator before advancing the port further. If a retaining collar is being used, this may be screwed into the abdominal wall as shown, and the position of the trocar within this may be adjusted as demonstrated. Remember that if retaining collars are used, they must be compatible with the trocar. Plastic trocars must have plastic collars, and metal trocars must have metal collars. Never use a plastic collar with a metal trocar. Further trocars may be inserted as required, and these are inserted in a similar fashion. It is important to keep the operative field clear and prevent any clashing of instruments and interruption of the field of view. Using the right work port, pass a grasper down into the cavity under direct vision and use it to pick up an object such as a cotton dental roll from a gallipot, and lay it down on the simulator floor. Release it. Pick it up again and replace it in the gallipot. Withdraw the instrument again under direct vision. Having completed this exercise, it should be tried from the left-hand port using the left hand. Once again, pick up the object from the gallipot. Place it on the simulator floor and release it. Pick it up again and pop it back into the gallipot. Withdraw the instrument. All moves should be under direct vision of the camera. Now, insert a grasper into both working ports. Pick up the dental roll with the right grasper and pass it to the left grasper. Place it on the floor of the simulator. Pick it up and pass it to the right-hand grasper and replace the dental roll into the gallipot. Now, repeat this exercise, starting with the left grasper. Pick it up, pass it to the other instrument. Put it down, pick it up, pass it back, and replace it in the gallipot. This seemingly pointless exercise will improve your manipulative skills and hand and eye coordination. The instruments may now be withdrawn from the simulator. Mark a circle on a rubber glove as seen here and pin the glove out on a cork board. The aim of this exercise is going to be to cut out the circle on the rubber glove within the simulator. We can't use scissors and forceps. We have to use long instruments inside the simulator. Place the cork board within the abdominal simulator. Insert the scissors through the right-hand port and a pair of graspers through the left-hand port. Use the graspers to pick up the anterior surface of the glove and cut out as accurately as possible the circle as marked. Use the left-handed grasper to display the markings on the glove, and be careful not to damage the other surface of the glove. Work round gently and try to ensure that the position of the scissors does not make the cut too ragged. Rotate the curve of the scissors to reflect as accurately as possible the actual line to be cut. Continue to work around until the whole disc is cut out from the surface of the glove. Here you can see that adequate rotation of the scissors allows a more accurate line to be cut. Once the completed disc has been cut out, this may be picked up by the graspers and removed from the simulator through the port. Therapeutic laparoscopy requires pedicles such as the cystic duct to be ligated and divided. Clip applicators are used for this, followed by division using scissors. We're going to use a foam tree to demonstrate these particular techniques. Familiarize yourself with the clip applicator so that you know how it should be used. This exercise will also require the use of graspers. The application of an endo loop will also be demonstrated in this exercise. First of all, practice using a clip applicator outside the simulator. Insert 3 clips onto one of the limbs of the foam tree and then cut between them like this. The ender loop should be loaded backwards into an introducer and pulled through it until the loop becomes entirely withdrawn into the introducer. Practice applying the ender loop on your assistant's finger. Allow the loop to emerge. Hook it round the finger and break off the end of the ender loop as seen here. You're then in a position to tighten the loop and to push the knot down using the shaft of the ender loop. Tighten as appropriate. Now place the foam tree inside the simulator. Use a combination of graspers and scissors to dissect out a portion of foam. This is another useful exercise in the manipulation of instruments. Use the scissors as appropriate, always ensuring that before you actually cut, you can see that the scissor tips are correctly placed. Remove the excised segment. Now practice with a clip applicator and insert clips onto one of the limbs. Then divide between them. Once this has been done, practice using the ender loop by inserting it into an introducer, which is then passed through the 5mm port. We are now going to perform a simulated appendicectomy using the finger of an inflated glove as the appendix. Advance the ender loop into the simulator and then extend the loop. Pass a pair of grabbers under direct vision through the other 5mm port. Hook the ender loop around the appendix, easing it over with the grabbers if necessary. Once you have the loop at the base of the appendix, grasp it and then tighten the loop by breaking off the end of the ender loop and pulling back on the thread. To allow you to do this, get your assistant to hold the grabbers. Pull on the thread at the same time as tightening the knot with the shaft of the ender loop until the knot is secure and tight around the base of the appendix. Once you are sure that the knot is tight, withdraw the shaft of the ender loop and insert a pair of scissors down the same channel. You may now cut the suture. You may now cut off the appendix, and if your knot is secure, the rest of the glove won't deflate. Surgical diathermy or electrosurgery involves passing a high-frequency electric current through the patient in order to achieve cutting or coagulation. The equipment is inherently safe, and the vast majority of injuries are due to failure of technique. In the first section, we will look at the principles of electrosurgery itself, consider its hazards, how these can be avoided, and finally consider the specific application of electrosurgery in laparoscopy. Electricity is the flow of electrons through a substance from atom to atom, driven by a difference in voltage between 2 points. Voltage is electricity's driving force. The higher the voltage, the greater the drive, and the more the flow of electrons. The simplest circuits to understand are those which involve direct